You can speak the recording. Thank you.
So yeah, first of all, what is tear trough? So it is the medial depression. It is depression in the medial lower eyelid, just lateral to the anterior lacrimal crest and limited in its inferior aspect by the inferior orbital rim. So we will understand the tear trough with various diagrams. And one thing which is important is that tear trough is present in children also. So it is not, we don't call it a sign of aging, because tear trough is present in children also, and it the look of it or the appearance of it depreciates with age. So when we see the anatomy, we have this is the orbicularis oculi ligament running like this one. Before that, I would like to discuss something like when we draw two ligaments we are discussing. One is the orbicularis retaining ligament and one is the zygomatico-cutaneous ligament, right? So how do you mark the orbicularis oculi ligament? You close your eyes, you slightly press the eye bulb, and the moment you press the eye bulb, you see slight bulge beneath the eye. So wherever that bulge is ending, that point is the orbicularis retaining ligament. Right?
So that is limited by the orbital rim.
Yeah. So we have the orbital rim. See. I don't know. No, I can't show the skull over here. Okay. So the orbital rim is there. From orbital rim, the orbicularis retaining ligament is coming out like this, horizontally. And from this ORL, orbital septum is going vertically. It's a thin sheet of septum. It's going vertically upwards. So if we see in this diagram, just give me. So in this diagram, this is the ORL. And the orbital septum is running like this, beneath the muscle. Excuse me, I don't know why this happens. Can I just take a pause? I have to stop sharing and stop recording.
Oh.
So this is, first we have to locate the ORL, right? Second is the ZCL, which is going from here, from like this. This is the ZCL. Right? So from the ORL, orbital septum is running upwards to the tarsal plate. Right? So where exactly we have to inject while we are doing tear trough is, we do not have to inject above the ORL, never. Never go beyond this line. We always inject in this area for tear trough.
Okay.
Right?
So you are injecting below the
ORL.
The orbicular retaining ligament and in between the zygomatic cutaneous and orbicular, you are in between these two ligaments.
Yeah. The pre-zygomatic space that we can say.
Pre-zygomatic space. And also, are we above the malar ligament or are we below the malar ligament when we inject?
We are above the malar. So if we consider this triangle, the roof is formed by ORL. The floor is formed by ZCL. The the backside, at the backside of it, we have the muscle or the superficial fat, deep SOOF. SOOF is deep fat. Then we have the muscle, and then above this muscle, we have thin layer of fat, and over that we have the skin.
Yeah.
So it is the soup that we are injecting in. We are injecting in the deep fat. It is, this is what we are replenishing while we are doing tear trough. This is our purpose.
So we are going deep into the fat, deep fat.
Yes, deep fat into the soup.
Mm.
Right. So now two things also, another I would like to add over here is that when we do with a syringe, right, this is, we are directly injecting into the soup. But then in the previous slides, we had mentioned that the CK3 point, anterior malar point, the anterior malar point, when we are doing CK3 is beneath the ZCL. This is ZCL. And beneath this, we are injecting.
Yeah. So when you're injecting, you are above the muscle and you are below the muscle. We are below the muscle.
Below the muscle.
Below the muscle, yeah.
And when we are injecting ZCL, we are putting the product over here. So we are supporting the ligament from beneath.
Yeah.
And when we are injecting the soup, we are replenishing the soup. Because when you see the aging of the fat pads, there are many papers, whenever you have time, you can read. The aging of the fat pads, how it's different for deep fat and superficial fat. The deep fat is the one which is getting deflated.
Yeah.
Right? This is the deep fat and this is the superficial fat. So the deep fat is
This is
getting
a deep and yeah, which is deep and which is superficial?
This is deep fat, and over the muscle is superficial.
Okay. Okay.
So in the face, the aging, when it happens, the deep fat is aging differently. Deep fat goes deflates, and the superficial fat descends.
Yes.
So when we inject deep, we are inflating back the deep fat.
Yeah.
And that is, we are doing volume repletion. That is, we are treating volume loss. And when we're doing with a cannula, or when we are doing CK3 point, we are actually realigning the ZCL to realign the superficial fat.
Yeah.
Right? So
with cannula, when we are doing CK3, we are realigning the ZCL. We are not going in this fat pad, deep fat pad, or are we going in the deep fat pad with CK3?
With CK3, we are just going beneath. We are not going over in soup. We are not going. We are going into the deep fat of the cheek, not the soup.
Okay. CK3 is the deep fat of the cheek.
Yeah, with a needle. With a cannula, it could be superficial. Try to, if we go deep with cannula, it's difficult to go deeper, but still you can attempt.
Yeah, there's a lot of cough. I think it's allergic cough. Is it?
No.
It's a dry cough. I know it's Delhi also.
Yeah.
Are you also facing a lot of pollution in Jaipur, like in Delhi?
Not much. Delhi is too much.
Yeah, Delhi. Yeah, Delhi is very bad. Everybody's having problem with the throat.
When I'm talking now, it gets worse.
Yeah, it's allergic cough. I can see that it's allergic cough. You need antihistaminics or something.
Okay.
To reduce it. Bilastine would be good.
Yeah, steam, I'll do it steam. That's why I got
Yeah,
late.
no, Bilastine. Yeah, Bilastine is good. Bilastine, Bilashine.
Okay. So this is about the teardrop. Then another diagram. We'll see this again. This is the ORL. This is the ZCL.
Orbicular ZCL. Yeah, this is the soup.
the SOOF over here. This is the orbital septum. This is the ORL,
Yeah.
which is horizontally. It comes like this. Orbital septum going vertically upwards to the
Yeah.
target plate. Behind this, we
Yeah.
have the orbicularis oculi fat,
Uh-huh.
right? And this is orbicularis oculi muscle, orbital part and palpebral part.
Yeah. And what is LLC SAN?
Levator labii superioris alegnesi, that muscle, which is the snarl
Okay.
muscle. You know, you snarl like this. Like if you're snarling, this is the muscle.
Okay.
LLSAN. Right?
Yeah.
This is the, again, anatomy. So that's the same slide. Yep. From the frontal aspect, this is how it's seen. We have the palpebromalar groove. This is called the red dotted point is called the Indian band, mid-cheek crease, mid-cheek furrow, mid-cheek groove, and a nasojugal groove. You can call it by many names.
Malar mound. Okay. Yeah.
And here in this triangle, you get the malar mound. Right?
And what is the palpebral groove? This is the palpebromalar groove. Is this?
Yeah.
Palpebromalar groove.
Yeah.
So palpebromalar groove is lateral and tear trough is the medial one.
Medial. Yes, yes, yes. So anatomically, when you see tear trough, it is actually this. It is the tethered ligament. It is the shadow of the ligament. It is a pull of the ligament on the skin, which is called the tear trough. But when we are injecting the area, we are injecting the hollowness caused by this ligament beneath it.
Yeah. Here.
So in face, there are always ligaments, and beneath the ligaments, we get shadows, because of aging. So these shadows, when we are treating, we are, replacing the fat or realigning the fat or realigning the ligament. When we are dealing with these shadows, they are always beneath the ligament because the ligaments are very, stubborn. They are very, they don't sag easily. They don't age easily. The tissue is very tightly bound in ligaments.
Yeah.
So anatomically, tear trough is the area where, the tear gets collected, and it is actually the tethering of the ligament to the skin, which is causing the tear trough. But when we are treating it, this is not the area we inject. We inject beneath it.
Beneath means this area.
Yeah, it's either anterior malar or the SOOF.
Okay, this. Oh.
Now what happens? Why do we get eye bags? The reason we get eye bags is because, see, ZCL is very, tightly bound to the bone, the zygomatic bone. So the orbital septum is a fine, thin membrane. So it gives so it's easier for the fat to protrude forward than go downwards.
Yeah.
Path of the least resistance,
Yeah.
So this is a diagram by Dr. Tim Pierce. This is how he explains, like this is the orbicularis retaining ligament.
Yeah.
Above this, we have post-septal fat. Beneath the ORS, we have SOOF.
Yeah.
These are the ZCL.
Yeah.
And this is the deep medial cheek fat.
Yeah. So when the malar mounds are found, what forms the lower border of this malar mound? ZCL is forming the upper border. What is forming the lower border? Which ligament is forming the lower border? The red line, Indian band. What is being formed by the?
It is extended. The ZCL is getting extended forward. This entire ZCL.
So, okay, this is ZCL only. Okay.
Yeah. This is ZCL only.
ZCL.
So this is the revised infraorbital scale given by Allergan. When we examine tear trough, this is a scale that we have to refer to that, we can, oh, sorry. So first, grade 0 is that no visible skin crease, no visible loss, medially or laterally, right? Then there is a medial or supple skin crease. Then we have, it comes medially, it becomes defined.
Yeah.
Then further it goes, initially it comes to the mid-pupillary line, then it goes beyond mid-pupillary, and then the entire, the orbital rim is in this,
Yeah.
right? So few things about the ligament. This tier of grading scale, if you want, I'll share it with you as a separate PDF,
Yeah.
right?
Yeah, that'll be nice to have it.
So the few things which are points that you have to know, that tear trough is very difficult. It's the most difficult area to be managed in face, because it is the area which is affected by seasonal allergies. It is the area which is
Yeah.
more affected by fluid retention. There can be lymphatic obstruction, right? And anatomically, two arteries are here. First is the facial artery.
Yeah.
Facial artery is running like this. It is superficial in this area. And then there is the dorsal nasal and the angular artery, which is going towards the. So this artery, we have to be careful, because this artery is superficial. So we make sure that our injection points are deep on the bone, right?
Yeah.
The second artery is the infraorbital artery, which is deep.
The arteries are the superficial facial artery, dorsal nasal, angular, and intraorbital that are coming in
Yeah.
this zone.
Yes, yes, yes. So the facial artery and branches, they are superficial over here. And they can lie anywhere between this area.
Yeah.
And the infraorbital artery is, just over here, 6 mm below the orbital rim. But it has the orbit is holding it. Like, the artery is going like this. See, if this is the orbit, the foramen is hooded like this. So artery is going down like this.
Yeah.
Right. So the best, if you're doing with cannula, the best point to entry point is not from beneath, but 2 centimeter lateral to the lateral canthus, and then 2 centimeter below. This is the entry point to get into the SOOF. If we are doing with cannula.
Got it. This. Yeah.
Right. And then in tear trough, we are not looking for perfection. In
Yeah.
tear trough, they say, if your patient is happy on the table, then you're in trouble. Because this area hydrates so much, and the thin skin, and the skin gives way to that hydration. So a minimal amount of filler also can give, drastic swelling if over injected. So this is the area where we are not looking for perfection. We are just looking for slight improvements.
Yeah.
Right. And
Yeah.
this is the area where we have to find out that where the volume depletion is there. So some people, they feel that they have dark circles. So this is not a treatment for dark circles. This is just the hollowness. Right? So under eye hollowness and under eye dark circles. If somebody is coming for dark circles, this is not the right treatment for them. If somebody is coming for hollowness, because people don't understand, they say for them it is both dark circles. Then second thing is 2 tests you have to do. One is the pinch test. If the skin is very loose, dermal filler and Botox are not a good idea.
What do you do if it is too loose?
Too loose, then inject deep and tell them that, you're undercorrecting, you're not overcorrecting. And it is not an ideal choice. It's not that we don't do, we do, but the results that would be expected otherwise in a normal person are not expected in this person, because we are limited to inject, because the moment we inject more, it's going to swell up.
Okay. So do you do anything else beyond fillers if the skin is too loose, or only
Can do
filler is the
RF,
only thing that?
radio frequency devices are there. They can help. PRPs can help.
In case you're doing RF, I think you will be doing RF before you do the filler.
Yes,
Or you
yes.
can do it after the filler
No,
also.
if you're
Before.
doing after, at least a gap of 1.5 months, after that you can continue with your RF, not before that.
Got it. Yeah.
So another reason why tear trough is more complicated is that orbicularis oculi is a very powerful muscle, right?
Yeah.
And it is an area where we keep moving continuously. So the filler displacement is very likely to happen.
Yeah.
So this is another reason you should always be in the deeper plane. So there are very high chances of filler migration. Yes. Now, when we use a cannula over here, it is a 25 gauge cannula. And we can, syringes when we use, it is always advisable to use the normal syringe rather than the BD syringe. Usually people, what
What
they
do you mean? Yeah.
sorry.
Normal means, what do you mean by normal syringe?
That comes with the, syringe, the needle that comes with the syringe itself. Some people,
Okay.
put it
All
in BD syringe, the filler, and then inject. It is not advisable in this area because there are a lot of small capillaries in this area. And with BD syringes, there's a high chance that you might end up hitting an artery or a vein.
Yeah. I always have a problem of bruising in this area.
Yes, because it is
I
very
try to, yeah.
it is very vascular. So it is very
So
likely to
I find
bruise.
it very difficult here. Patients get very upset. We tell them also this can bruise, but they get very upset if there's bruising because there is always a downtime to it.
Yeah.
And yeah, so that's a big problem for me. The bruising is a very big issue for me, like in this area.
We'll work on this. It's and two things are there when you do with cannula or you do with syringe.
Uh, if I go with a syringe, I go perpendicular.
Okay.
So I try to go perpendicular and just deposit it, and like CK3 and points around CK3. If I'm going with cannula, I was not going laterally. I was going from the medial side. I was going I was going lateral to the mid-pupillary line down. I was not going from the lateral side. That's the point that you told. So I was going just lateral to the mid-pupillary line and from below up.
Okay. No, from below up, usually they say it's not. If you're doing cheek, then also laterally entry point. And if you're doing only tear trough, then laterally like this, horizontal, 2 centimeter.
Okay, laterally. Okay.
Right.
Lateral entry is always better, you mean?
It is always better.
Yeah.
See, for an experienced person, everything is fine, But if there is a right way or not the right way, there is no right way actually. But if there is a way which we know, which can prevent something is happening, why not?
And another thing is when we're using cannula, we should first go perpendicular and then slide along the bone and then go along. Is that the right technique?
Yes. So you pinch the skin, make your entry point, and then put the cannula. When you're putting slightly 45 degrees and then go parallel. That will be subcute. That entry is 45 degree and then parallel, that is subcute. And if you're going to the deeper plane, then you have to go really in. Entry could be like 45 degree to 90 degree, anywhere between 45 to 90. And then you should be able to feel the surface of the skin, of the bone or something, you should feel that, gritty feeling. In the subcute, the cannula is free flowing. It's
when
easily.
we are injecting, our idea is to be below the muscle.
Yes, it is always below the muscle.
So we have to be on the bone for that.
Yes, we have to be on the bone.
So even if we are doing with the cannula, we have to be on the bone.
Try to be in a deeper plane. Yeah, not superficial.
So we'll try to hit the bone and then go parallel to the bone with the cannula also.
Yeah. So the next point that I have to discuss is that, cannula has its pros and cons, and needle has its own. So needle, with the cannula, there are more chance of edema and less chance of bruising. With the needle, there are more chances of bruising and less chances of edema. So both have pros and cons. It is just how you can, what is best for you, you have to see. And best for the patient, the approach. Sometimes with needle, you cannot approach it. If you have a lot of face fat, a direct needle approach is quite difficult.
Yeah.
Sometimes there is tear trough and then a lot of facial fat. So a step kind of a thing is formed. You form a step over here. So then in that cases, it's again very difficult.
Yeah. And which product are you using for under eye?
I usually
Is it
use Volift or Ultra Plus XC or Volbella. And if I'm doing the cheek, then with a needle CK3, then Voluma.
Yeah, yeah.
So ideally they say Volbella is best, but when you're going deep, then Volbella doesn't work. So it is Volift is fine.
Volift would be better.
Volift or Ultra Plus XC.
Yeah, but Ultra Plus XC can be quite hygroscopic.
Yeah, it hydrates. So very little quantities, 0.01, 0.02. On the bone, that too.
0.01 to 0.3.
No, 0.02. 0.1 to 0.01 to 0.02.
Yeah.
Right. Now, another thing is when people inject behind the orbital septum. In first two mistakes, what usually people do is they inject above the ORL or they inject behind the orbital septum. So if you go behind the orbital septum, the product can stay for more than 10 to 12 years. As it is, MRI studies have, proven that the product is there. It can be found even after 10 to 12 years. So if you are above the ORL or behind the orbital septum, it's a trouble forever. Because behind the orbital septum, if it is placed, it is very resistant to even hyaluronidase also.
So we should never cross ORL.
Yes, never, no matter what. Because actually the problem will be seen in the ORL area only. But always beneath the ORL. So if filler gets behind the orbital septum, then it is there to stay for years to come.
Yeah.
So the idea is to prevent and designing an injection technique which will help you stay out of this area. So do the markings first. First mark the ORL. First thing you mark is ORL.
Yeah.
And you can stay beneath it. So the complication that people have with intra-orbital area is the periorbital edema. That is very common. It could be immediate also, and it could be delayed also.
Yeah.
So any fluid buildup, it can be seen. So this has to be, if someone has a tendency of puffiness, hypertension or something, all these metabolic issues, diabetes and all, or some individuals are as it is prone to getting puffiness, periorbital puffiness or edema. Be careful in those individuals.
So we should under inject in them or what?
You have to tell them, try to and we are as it is under correcting in all the individuals. But in those individuals, you have to tell them that there can be a puffiness or swelling, which can get aggravated because those people, they get then hyper, they have functions 2-3 days after and they'll keep coming to you. Now, what do I do? So that is not the time to put hyaluronidase also.
So what do you do with people who have a tendency for puff, this edema? Do you inject or not inject, or how?
You inject, but tell them first of all there should be no social obligation for another 15 days, and you break the session into two sessions. Don't inject entire in one session. Do a little bit of injection one day, and then after 15 days, if required, reassess and then inject again.
And how much do you put in one session normally?
0.1 to 0.2
Total
total.
volume or per point?
Per point. We will be coming to those
Per
points
point.
in the MD codes.
Okay. So
Right?
total volume, how much are you using in under eye
0.3
normally?
each side.
In a
0.3 each side.
0.3 each.
Yeah, 0.1, 0.1, 0.1. Like that.
Okay.
So usually there is no perfect formula. There's always a downside, and you always have to trade off something. So there's nothing called a perfect formula. So it's like that.
Yeah.
So what in tear trough, what you see immediately after tear trough is not the true result, right? Because the skin is fine, the product is hygroscopic, and combined with the goal for perfection. So it's like a tightrope blind walk sometimes. So this is the most difficult and the hardest area to treat. There is no room for error, because again this is a very important aspect of the face. And precision of injection and predictability of product over time, these are the two things that we have to keep always in consideration. And as I said, filler will last for much longer than it is mentioned on the boxes. Now the filler is blind to the orbital septum, right? That means that orbital septum is a very thin septum, and the purpose of orbital septum is to protect the eyeball from any external anything. So if the filler is placed behind the orbital septum, even hyaluronidase cannot help. This is a study by Dr. Chan. Dr. Chan, Dr. Master. So the element to take home in this is that stay away from the orbit.
There's a lot of cough, I hope. Yeah. Are you okay to continue, Dr. Bhavna?
Yeah, it's fine. Some only 3-4 minutes left. So there is a slight millimeters difference, between the right point and the wrong point. So you have to be very little. Do your markings first. The no-go, mark the infraorbital foramen, mark the ORL, mark the ZCL, do the markings, and then start the fillings.
And our filling has to be between ORL and ZCL.
Yes, always.
Yeah.
So now there is grading of tear trough. Tear trough shadows can be primary and secondary. Primary shadows are, as I mentioned, young individuals. It is a tethering of the skin. Even kids have, even in children, you can see tear trough. That is because the ligament is tightly tethered to the bone and skin. So that is the primary tear trough, which is not, we are treating. The secondary tear trough is something which is that age-related disruption between the several fat pads and the ligament. And the boundaries between the ligaments becomes visible with various compartments and ligaments. It becomes visible, and these are the shadows that we are dealing with. So we are not treating the primary tear trough shadow. We are always treating the secondary tear trough shadow, which is a result of aging process.
Can you again tell what is the difference between primary and secondary tear trough shadow?
Primary is like a young patient coming for under eye dark circles or under eye hollowness. They might have under eye hollowness, but in them it is not age related. So you have to make out whether it's like a volume loss kind of a thing, or it is something which you cannot. If it is a primary shadow, you cannot treat it anyway, because you cannot inject over the ORL.
Yeah.
You can slightly improve by doing the cheek or CK3.
Yeah.
But you cannot do the tear trough.
Okay, and what is the secondary shadow?
Secondary is you see the ligament and the fat boundaries.
Okay.
See these HCl going like this. You see the ORL, you see the bulge. Now another test is like, you slightly earbud test. They say you with a bud, you slightly press this area, anterior malar area. If by pressing this area, there is an improvement in the tear trough, then they're the right candidate for tear trough fillers. Right? This
So
is
with the earbud, we are pressing on the ZCL
yes, in the anterior malar.
anterior malar.
Which is called the
Yeah.
that is the earbud test. Gentle compression of the area beneath the tear trough ligament is can show how the raising of the fat pad as it meets the ligament affects the shadow.
Yeah.
So there are multiple fat compartments around the eye and they can contribute to the tear trough shadow. We have the post-septal fat, which herniates from the orbit with age and creates a shadow. There is SOOF, which atrophies with age and causes the shadow. And there is the mid-cheek fat pad, which atrophies and causes a shadow. So all the patterns of lights and shades are darkest where we find the ligament. So beneath the ligament, we'll always find a shadow because of the atrophy of the underlying fat. So that is the shadow that we are creating again. We are rebuilding that, correcting that shadow. Right? And if these are age related changes, then the underlying cause and altering